Good morning and thank you. For the next 13 minutes, we're going to change gears to talk more about open aortic surgery, which we still do in select situations. Here are my disclosures. So there's no question, as you've heard already, EVAR and FEVAR have drastically changed the treatment of juxtarenal and infrarenal aortic aneurysms. However, open pararenal aneurysm repair remains the standard of care for a variety of reasons. These typically are higher risk procedures done in higher risk patients. The cardiopulmonary and visceral ischemic complications thereafter are quite problematic. Numerous large institutional studies have focused on acute renal dysfunction, noted as ARD, and this significantly impacts morbidity and mortality in the early and long term. So this is what we're going to focus on, not the juxta, but more so the pararenal and the suprarenal aortic aneurysms. First reported by Crawford in '86, looking at pararenal aortic aneurysms combined with acute renal dysfunction. Today, 2016, it still remains a common problem. It's associated with increased length of stay, non-renal related complications, mortality, and increased cost. And the risk of developing acute renal dysfunction at this point is multifactorial. Often pre-existing comorbidities, intraoperative decisions, techniques, iatrogenic injuries, and postoperative management will dictate the incidence and the end result. So with current data, what is it we know? With open repair of all comers in the Medicare database, approximately 10% will develop ATN at 30 days. At 1 year, the incidence is 0.5%. A large meta-analysis looking at open pararenal repair demonstrated the incidence was higher, between 15 and 21% for acute renal dysfunction, and the end result being hemodialysis at 1 year, 3.5%. If you look at all the aneurysms we talked about earlier, or at least what you've heard about today, the incidence with infrarenal aneurysms is 1 to 13%, juxtarenal between 0 and 39, pararenal between 4 and 39, and the thoracos, not surprising, between 5 and 40. A paper that came out of Pittsburgh, Geetha looked at a comparison of modern open infrarenal repair and pararenal aneurysms and the early results with renal dysfunction at 1 year. It was a retrospective review, large number of patients, 432 over a 7-year period, and they compared infrarenal, for which 233 were noted, and pararenal, 184. They specifically defined acute renal dysfunction as a rise in your creatinine by greater than 0.5. Clamp time as a whole was 29 minutes. Cold perfusion was used in a very small number. And postoperatively, not surprising, for those with an infrarenal clamp, the renal dysfunction rate was 13%, and for those with a pararenal, it was 32%. Focusing in on the data, what we noticed is that they did predictors of in-hospital mortality with logistic regression analysis. You can appreciate the following information with the odds ratio. Those patients who had underlying renal dysfunction based on a creatinine of greater than 1.5, those with coronary disease, a postoperative MI, and pulmonary complications were at the higher end of incidence for developing acute renal dysfunction. A paper from Grant. So what are the risk factors for renal failure following open elective aneurysm surgery? And this is basically paraviscerals, pararenals, juxtarenals, and open. The end result was the following. Renal failure following open elective AAA repair is associated with increased risk of mortality, and he honed in on, using logistic regression model, which factors are most significant. Some of this might surprise you. Age over 75, those with symptomatics, those with respiratory disease prior to the operation, those who are ongoing treatment for hypertension, not surprisingly, those with juxta and suprarenal aneurysms, and once again, we're falling back upon the premise that pre-existing comorbidities are problematic. Again, those with underlying renal dysfunction. This was a fairly large trial, and if you look at the overall 30-day mortality, it was 35% for people that fell in that category with a higher risk versus 4.3 who didn't. Du Bois looked at the technical factors. So not only is it pre-existing health-related issues, but it's also technical factors that will dictate the end result of acute renal dysfunction. This is a single-center study from 2000 to 2011, 169 open juxtarenal repairs. Average clamp time, 29 minutes, probably a little bit longer than one might expect. 16% had adjunctive renal procedures. The renal vein was ligated in 11%. Postoperatively, over a third developed acute renal dysfunction that would be based on a GFR greater than 50% from the baseline. Most of this cleared before the patient was discharged. What they did note from all the data is that the clamp time over 34 minutes was the strongest predictor of an adverse event. If you look over at the logistic regression, you can appreciate the following: clamp position, renal ischemia time, left renal vein division, and renal procedures such as endarterectomy, which prolonged the procedure, were the major factors which led to the acute renal dysfunction. So here's what we know in a summary. Aortic cross-clamping is not so good. It's a combination of atherombolization to the branch vessels, mesenterics, and lower extremities. This in turn increases your renal vascular resistance, decreases your GFR, all of which is mediated by your renin-angiotensin system. This will persist up to 1 hour after your cross-clamp is released. Added factors, obviously from that standpoint, the prolongation of a cross-clamp, underlying renal dysfunction, intraoperative and postoperative hypotension, hypovolemia, age over 75, and also those with myocardial dysfunction, we have a decreased cardiac output. It's important to recognize the following: the intraoperative urine output doesn't correlate with postoperative renal dysfunction, primarily due to the fact that ATN in the early period is due to sloughing of your tubular cells, and in turn, those tubular cells will obstruct the luminal flow and distort your glomerular architecture somewhere between 24 and 72 hours later. And that's one of the reasons you're going to notice early on, along with some delusional effect, that your creatinine typically doesn't change until a 24 to 72 hour window after the procedure. And if you recognize that, you can notice the following: that for those patients that deteriorate, necessitating dialysis, their outcomes are very poor. So it's logical to conclude the following: that acute renal dysfunction should be reduced by the following: advancements in technology, refinement in patient selection, improving our surgical techniques, and perioperative care. Unfortunately, we really haven't seen that drastic change with all that we've invested over the past 2 decades. We'll accept the fact there are a few things that should be done preoperatively. I think a thorough cardiac, pulmonary, renal evaluation to make sure that those comorbidities are optimized is incredibly important. Making sure the patients are on statin and antiplatelet therapy, primarily to reduce the perioperative cardiovascular events. Address any concomitant renal disease. For example, if it's a patient who has a stenosis of the renal beyond the ostium, this might be a patient who's a little more challenging to approach from a retroperitoneal access. And you may want to think about, maybe this is a patient who I put a stent in before I do my RP approach. Or is this someone who I should go transabdominal? And as important, make sure your imaging is complete. Clearly, one of the most critically important components of this is choosing the right site to place your clamp. One, from the standpoint of minimizing your risk of atherombolization, but two, decreasing the chance of having to reapply your clamp after the first time, because you know as well as I, clamp injuries can be fatal. What does he do in the perioperative, or at least preoperative period? IV hydration, typically 1 ml per kilogram for a 12-hour window, I think is advantageous, especially for those patients who have chronic kidney disease 2, 3, or 4. Mannitol, clearly beneficial before your clamp is applied. We know it's a scavenger for oxygen-free radicals. It's also an osmotic diuretic. And most important, I think sometimes we fail to appreciate that, is avoiding your nephrotoxic agents, specifically ARBs and your ACE inhibitors. Now, there's a lot of other medications that have been recommended, discussed, presented, but there's very limited data supporting the use of Lasix, dopamine, and acetylcysteine, and certainly phenoldipan, which has been discussed on many fronts in the past few years. Techniques and options for minimizing, but not completely preventing, the ischemic effects associated with cross-clamping. So hypothermic circ arrest, helpful for probably not applicable in this situation. Distal aortic perfusion certainly is beneficial if by chance you feel it's going to be a prolonged cross-clamp. I think in patients who have complex pararenals, suprarenals, and type 4s, it is advantageous. And going through the details of these types of perfusion means, distal aortic perfusion, are beyond the scope of the presentation, but you can see there's a variety of options available. Inline mesenteric shunting, I think, is critically important from the standpoint of making sure that you're perfusing your mesentery if indeed it's a prolonged cross-clamp time. And it's important to recognize that normal thermic renal perfusion is ineffective for preventing acute renal dysfunction. So what is it we like to do? I think moderate heparinization is completely applicable. Permissive hypothermia, where your core temp stays above 33, is very, very helpful and beneficial to minimize, as you know, non-surgical bleeding, which is sometimes an issue. Make sure we're placing your clamp in a relatively disease-free aortic segment, minimizing atherombolization and minimizing the need to reclamp. Limit iatrogenic trauma, whether it's the left renal vein, the left renal artery, the SMA, all of which I've seen. So the goal here is to minimize the need for urgently initiating your anticoagulation, urgently clamping, prolonging the warm ischemia. We certainly want to make sure that we initiate cold perfusion early on, and this is most beneficial with the use of 9 French Pruitt balloon catheters and expedient renal vascularization within a 30-minute window. So cold renal perfusion is beneficial, no question about that. There's a large amount of data that's out there. It induces hypothermia, which in turn lowers the metabolic demand and oxygen demand of both kidneys. It lessens the ischemic effects. For every 1 degree Celsius the kidney is cooled, there's a 7% reduction in renal metabolism. And if you extrapolate that, cooling the kidney by 30% will cut the metabolic demand in half, all of which is incredibly important. The solution we typically like to use is LR. You can also use normal saline. We'll typically prepare 3 1-liter bags. I'll add my mannitol, methylpred, and also the heparin. When we open up the belly, place our clamp, both kidneys are flush. Typically, I'll use a Christmas tree adapter, and then we'll insert our 9 French catheters. During that procedure, we'll administer 150 C aliquots every 20 minutes. Now, there was a time that this used to be a combination of both vascular and anesthesiology, but one of the problems I ran into a couple of years ago is that when you do place your catheters into both renal arteries, which you can see are highlighted with 1 blue arrow, when we do place the catheters in, instill the initial fluid, one of the techniques that we used to apply was hanging the ice saline from an IV pole and allowing the anesthesiologist to administer it. Well, unfortunately, from a bad memory of the past, one of the anesthesiologists was successful in administering 2 liters within 1 hour to both kidneys, but failing to tell me. And then we appreciate the fact that the patient was clearly hypothermic. So when I realized that I lost the control of the operation because of decisions that were being made on the other side of the ether screen, it led me to change my plan. So the technique that I apply now is using the two-method pump. The same two-method pump that we'll typically use for RF ablations or EVLT ablations. I'll actually attach that to my perfusion crystallite solution. That gets elevated, and then I have a timer in the room so that every 20 minutes go by, I'll know to step on the pump, and we can clearly determine the amount of solution that is being administered on a regular basis, all of which is being administered through those 2 9 French catheters. So once again, we've taken control of this, and the amount of solution that is being administered, I've probably cut down by 30%, and that gives us more control. And this is an example of where we've set things up. You've got your 2 perfusion catheters into both kidneys, the bag of your ice saline being elevated, and the foot pedal, which allow me to administer it as needed, with the bell going off every 20 minutes. Your focus of attention is on the operation itself until that bell goes off, and then we'll step on the pedal. So interoperatively, what is it we do? You're going to make sure that you vary your surgical technique. If there's a possibility of just having to reimplant or bypass 1 kidney, take advantage of it. So bevel your anastomosis if possible, but always make sure you're sewing to normal aortic tissue. These 9 French Pruitt shuts are malleable. They're almost elastic feel in nature, but they can cause branch vessel trauma. You can easily perforate a vessel. You can induce a dissection, especially if there's an osteostenosis, and you can over-endoflate the vessel, rupturing it all together. So be cognizant and be gentle. Avoid fluid overloading your patient, and be cognizant of the fact that if you do administer a large amount of the ice perfusion, you may in turn induce systemic hypothermia. So there's really good data clearly supporting hypothermic renal perfusion. It's effective at reducing renal failure. We acknowledge the fact that renal ischemia time is the strongest predictor of mortality and adverse events. Typically, if we keep it less than 23 minutes with juxtarenals, patients tolerate it well. If it's longer than 30 minutes, we notice that the recovery of renal function takes a prolonged period between 3 and 9 days. And using a sensitivity analysis, we notice the fact that ischemic time over 32 minutes is predictive of early mortality. I do think there's a role for debranching very selectively. This was initially presented in '99 and followed up by Gustavo when we looked at the North American debranching cohort. And with that being the case, I do think that minimizing your warm ischemia in patients with advanced chronic kidney disease stage 4 is advantageous. And you know as well as I that you can do debranching procedure relatively quickly, and the warm ischemia induced to that kidney can be less than 10 minutes. So I think there's something to be said about utilizing debranching technique in patients that have chronic kidney disease stage 4. Now, what happens when you operate on those patients with significant kidney dysfunction preoperatively? Well, this is some pretty good data coming out of Mass General. This was a NISCOP review from 05 to 08. 2,890 people, open aortic aneurysm repair, chronic kidney disease between stages 1 to 5. 5 is dialysis. The operative mortality was 10.3% for those 4 and 5 patients, and morbidity 40%. So it clearly tells you that pre-existing underlying renal dysfunction is a marker for adverse events and increased mortality. So in conclusion, pararenal, suprarenal aneurysm repair are complex clinical entities represent significant surgical challenges. Expeditious repair and renal perfusion are essential to minimize your renal dysfunction, which is significant and remains a common complication even in 2016. Adjunctive techniques, as we discussed, that support renal function should be utilized during the repair, and the ultimate goal is lowering your postoperative ischemic nephropathy, and in turn should improve your length of stay, lower your morbidity, and decrease your all-cause mortality rates. Thank you.